Now we'll go to the next session with our eminent speaker, Professor Dr. Ashraf Tayar. He is one of the eminent figures in the critical care ultrasound. He is a director of the ICU department, the Security Force Hospital in Dammam, and he is the European Society Intensive Care Medicine Task Force member of critical care ultrasound. I think anybody want to learn anything about the critical care ultrasound in the critical care unit in the ultrasound should hear from the Professor Dr. Ashraf. I really enjoy all his sessions everywhere. So I think we can start with his talk about liberation from mechanical ventilation and how to manage the failure. Thank you, Dr. Ashraf, and thank you for joining us. We really enjoy your talks everywhere. Thank you very much.
Thank you very much, Dr. Muhammad and Dr. Abu Shadi, for this very kind invitation. It's my pleasure really to join your activity. And I hope you see my slides, Dr. Muhammad, and you hear my voice very well.
Yes, it's clear, Dr. Ashraf. The slides are clear and your sound is very clear. Thank you very much.
Great. So without any further delay, my target and my task tonight will be to make it very simple for you with certain direct messages that I'm very keen to deliver. And this will actually focus on mainly the role of critical care ultrasound in anybody that you try to wean in your ICU. I have nothing to disclose for this presentation. And as we know, as everything in this life, weaning from mechanical ventilation carries either the possibility to succeed and then you extubate, and there is also a possibility of failure. And actually, the weaning practice is around 40 to 50% of the duration of mechanical ventilation in ICU as per evidence. The time is delivered and assigned to wean those whom we intubated already. So you have to think at a given time when you have to take off this mechanical ventilation. And that's why the American and North American, they like to call it liberation from mechanical ventilation rather than weaning. And you have to always keep in mind that both of leaving patients on ventilator unnecessarily and also the rush and hurry to take them off the ventilator while they are not ready, both of them are bad. So it's bad to keep your patient unnecessarily on ventilator, but also it's very bad and associated with mortality and morbidity to wean those who are not yet ready to wean. This has to be in mind all the time without any lot of talk about this. It's settled in the literature and in the science of weaning that when you start to liberate somebody from mechanical ventilation, this has to be tackled very vigilantly to know if they are ready to wean or not. This is mandatory. And you have to keep in mind that despite all the precautions we might take, there is a possibility of 25% of failure to wean. 25% failure to wean or failure to liberate from mechanical ventilation, though the readiness criteria was fulfilled. And the re-intubation rate is very high in ICU actually. We're talking about in most of the literature that almost quarter of patients that we extubate, and we definitely extubate them, when we believe that they are ready. I'm not talking about people who are taking it lightly, and we see this type of physicians, but I'm talking about those physicians who are taking it very seriously, knowing that their patient has to be ready. Despite this readiness, 26%, even when you extubate them, they require to be re-intubated. And we call this one of the criteria of extubation failure is that your patient required to be re-intubated within 48 hours of extubation, or those who require to be non-intentionally, of course, to be on non-invasive ventilation in or within the 48 hours. So you extubated somebody, but still he or she needs a sort of invasive, non-invasive ventilation, CPAP, BiPAP, whatever it is. And some people nowadays, they started to include also the high flow nasal cannula / with non-invasive ventilation to define the extubation failure. Not only that, but death during the 48 hours post-extubation is considered, of course, extubation failure, a complication of liberation from mechanical ventilation that is very detrimental. Extubation failure is very detrimental. And that's why you have to do all cautions and all efforts not to miss single case and to try to be very vigilant to know that your patient is ready. And I'm sure that this criteria are everywhere. As I said, I'm going to focus on my target of this presentation, which is, am I dealing with a patient who can be weaned and who are ready to be weaned from 3 different organs? Particularly if the risk to fail is very high, and risk of failure will increase in old age compared to young age. COPD patients, high a requirement of high minute volume, those with positive fluid balance, and those with prolonged mechanical ventilation, of course, they are at higher risk of extubation failure. And this has to draw more attention to those group of patients. So optimizing the time and the condition before you attempt to wean has to focus on many things. I'm sure also you know all of these, that no sedation, the fluid balance has to be kept AU or toward the negative side, no fever, no electrolyte issues, no current hemodynamic instability, and many, many other important things. And Dr. Abu Shadi took us through different moods. But what is very important is to have a protocolized care. The protocolized care found to be better in liberating patients from mechanical ventilation compared to a non-protocolized care. And protocolized care here should make the highlights on that you have to know what you are doing, and colleagues in your unit has to be in the same boat, thinking the same way, doing the same management, because this is one of the drawbacks in some of the ICUs or bad things in ICU, that the team might have different opinion. You love to wean patients on this mood or that mood, but you forget the principles. Regardless of the spontaneous breathing trial way, you have to be sure again and again that the organs are ready to be weaned. And there are 3 important organs that you have to pay attention, great attention to them. Some people, they call the protocols of A, B, C, D, E, and A refer to the airway and the lung, of course, and the B indicates the brain, and the C indicates the heart, and the D indicates the diaphragm, and E indicates the endocrine issues. Let me focus here on because this is a session for critical care ultrasound on this very vital organs in this critical time of liberation from mechanical ventilation. The lung, the diaphragm, and the cardiac function, because any disturbance of these three organs would result ultimately in failure to wean. There is no doubt of this. If the lung is not ready or affected badly by the process of weaning, or the heart or the diaphragm is not ready, then you're not going to succeed to wean. I'm not going to repeat what Dr. Abu Shadi mentioned clearly and nicely, but the lung. We all know that there are three things that compromise the readiness of the lung to be weaned. Do you hear me, Dr. Muhammad?
We can hear you, Dr. Ashraf. Yes, we just muted the other sound. Yes.
Okay. The airway resistance, if increased, the compliance, if decreased, and compliance of both lung and chest wall. And of course, if you have intrinsic PEEP, this will increase the respiratory muscle load, and then this might help to fail patients from mechanical ventilation. The airway resistance will increase because of many things: ET tube, kink, secretions, bronchospasm in the airway, tracheomalacia, tracheal stenosis, granulation tissues, mispositioned tracheostomy tube. Many things increases the resistance. And in COPD patients, when they are not treated well, or asthma as well, you're going to have a lot of things that generate a dynamic hyperinflation or O2 beep, and then the airway resistance will increase. Many things that makes the compliance bad, like atelectasis, fibrosis, consolidation and pneumonia, the chest wall compliance will be reduced in obesity, in increased intra-abdominal pressure, in presence of significant pleural effusion. And all of these things can be backed up very nicely by the lung ultrasound. I'm not supposing here that we don't know how to do ultrasound or how to read ultrasound, because I know for a fact that these things can be learned very easily. For those who did not start yet the journey of critical care ultrasound, learning how to do it and how to practice with, keep in mind that these things are learnable, and you can reach the stage of the basic requirement that you need to manage in ICU or in acute medicine in general, ER or OR, with no difficulties, because people, they are doing this in daily practice with no difficulties. It's very easy to recognize what we call it the artifacts in the lung, namely the B lines. And as more as you see these B lines, which are vertical lines, I'm going to show you slides now, it indicates if it's numerous B lines in the field that you are seeing with the lung ultrasound, it indicates that you are dealing with an extra amount of extravascular lung wound, wet lung, or pulmonary edema. You have to keep in mind that if your patient's lung is derecruited while you are trying to wean, you're going to see this in sort of collapse and or consolidation. And of course, if you don't see sliding, you don't see the pleura moves back and forth well, then you're probably dealing with either adhesed pleura or no air entry going to the side, or pneumothorax. And all of these are very essential to diagnose, and actually they're gonna be detrimental if they are there while you are attempting to wean. And the danger, ladies and gentlemen, is that most of us rely on the chest X-ray in daily practices. And you know, it's known for fact that the chest X-ray sensitivity in most of the pathology in critically ill patients are around 40 to 50%. And the specificity also of these different diseases is around 50%. So you might miss in false negative around 50% or false positive 50%. You might have clear lung parenchyma on the normal, on the chest X-ray, while the lung is full of water actually. And this is how we see the vertical lines. They are vertical, connected to the pleural line, moves with the pleura, as you see differently in this loops here. And this pleura has to be noticed if it looks like healthy or diseased pleura, when it's a thickened, interrupted, corrugated, not smooth, and associated with subpleural, under the pleura, areas of hypoechoic shadowing with white dotting, as you see here in the bottom. This indicates a pleural consolidation. Those vertical lines, when they are seen in one intercostal space, the space between two shadows, black shadows, as you see here, of the ribs, this is the intercostal space, we call them B lines. If they are more than two in every intercostal space, we call this pulmonary edema. If this is associated with what looks like dirty pleura or thickened pleura or abnormal pleura, we call this a non-cardiogenic pulmonary edema. While if it is associated with a looking normal pleura in some areas and some other areas diseased pleura, this is typical for ARDS, what we call it the area, the spared area in ARDS, the non-homogeneous distribution of the B lines are consistent with pulmonary non-cardiogenic edema. While if you see here this loop, the pleura is attached with a lot of vertical lines that moves with the pleura with a normal looking, enhancing, smooth, shiny pleura. This is cardiogenic pulmonary edema. And this is with abnormal pleura and some other signs of infection or consolidation. This is a non-cardiogenic pulmonary edema, what we call ARDS. Consolidation is found to be pathognomonic in patients who behave clinically like having pneumonia or infection. And the lung ultrasound is the only modality that gives you live picture of the lung parenchyma showing the air bronchogram while it goes back and forth with inhalation, as you see here. The white threads here, lines, are air. This air goes in and disappears. Goes in when the air goes into the alveoli and goes out when the expiration happens. We call this dynamic air bronchogram. While when you see here on the left side that the dots, the white threads or dots, majority of it does not disappear with inhalation. This indicates static air bronchogram. The dynamic is a referral to consolidation, while the static refers to collapse. Not only that, but also in majority of cases, you see both consolidation and collapse. Again, comparing to the chest X-ray, the chest X-ray being seen negative or normal doesn't mean that the lung is free. And this is one of the clear messages that I want to deliver tonight, is that when you see the chest X-ray in your round in a winnable patient is normal, don't believe on this, because there is 50% chance that this might be false negative. And actually this picture or loop was from patient who looked totally in normal chest X-ray. This is the liver here, and this is the diaphragm encircling the liver, and this is the area above the diaphragm refers to the lung. And you can see here areas of air bronchogram and fluid bronchogram. See the black areas here, it indicate either there is a retained fluid inside this parenchyma, it indicate a very bad pneumonia, which is obstructive type of pneumonia or post-pneumonic obstruction, which requires in majority of cases, before you attempt to wean, that you have to open this feeding bronchi before you attempt to wean, because weaning those type of patient carries the risk of failure to wean or extubation failure later on. On the other hand, if you deal with this pathology before you wean, and you delay the weaning to do the bronchoscopy or to do more peeping to open or recruit the lung, would be much better than you wean, you fail, you re-intubate, and you increase the morbidity and mortality. The pleural effusion, which is very commonly encountered in critically ill patients, are one of the major oppositions to the success to wean. If you have significant amount of effusion, the lung will be collapsed, will be consolidated, and the diaphragm will not be able to generate good tidal volume after extubation because of this pleural effusion. And if you see evidence that the effusion is big and the lung, as you see here, is entrapped, then you have to relieve the suffering of the lung before you attempt to wean. Otherwise, again, you probably fail. The beauty of the lung ultrasound doesn't stay here or doesn't stop here, but it extends to tell you if you are dealing with a complicated, probably parapneumonic effusion, if you are able to see cells lively floating inside this pool, a vision that you will never see with even the CT, because the CT will tell you that you're having a effusion, lung is consolidated, the parenchyma is consolidated or collapsed or wet, but the CT, which is the gold standard, as people like to call it, will never tell you if you are dealing with effusion, which needs a tapping with intercostal tube or with a simple drainage with a needle or with a pigtail, or even you have to consult cardiothoracic surgeon for acquiring that patient might require local thrombolysis in very adhesed, complicated, septated effusion that we commonly see in patients, especially malignant patients and post-pneumonic patients. So collectively, the lung ultrasound is mandated before you attempt to wean, because it tells you in details if this lung is suitable and ready to be weaned off this positive pressure, this support with mechanical ventilation, or not yet ready to be weaned. And there are a lot of things and a lot of ideas and a lot of information that the lung ultrasound might surprise you for. Again, keep in mind that relying on the chest X-ray is considered non-practical and sometimes considered to be misconceptual management in ICU patients. There are a lot of schools of where and how to do the lung exam. you might simplify it to the most simple things. You at least examine the lung of your patients anteriorly in zone 1, which is the area between the sternal line and anterior axillary line. Zone 2, which is the axilla between the anterior and mid axillary line. And zone 3, which is the PLAPS area, the most dependent area on each side, and you compare bilaterally. So you do the exam whatever way you like, but as more as you see A lines sliding pleura in anteriorly and posteriorly and the middle of the lung, the more you are sure that this lung is aerated. And the more you see B lines, the more it indicates that this parenchyma, the area in between the alveoli and even the alveoli itself, might be flooded with extravascular lung water, and this water has to be drained before you attempt to wean. And the more you proceed to C, which is consolidation/collapse, the worse is the condition. So the worst sign that we see pre or during or after extubation is to see C, which is consolidation. People, they rely on this to have a score of what they call it, the lung score, bilaterally. For every area you put from 0 to 3. But there is no need for the sophisticated, academic, interesting lung ultrasound tool, but you need to examine, and you have to be very happy when you see a lung like this, pleura and A lines, no B lines. This is aerated lung. And the pleura here is sliding very well. You're gonna be less happy if you see B lines. You have to be very, very worried, and you ask yourself many questions before you go to this stage of the bottom here, when you see a lot of consolidation with effusion. If your patient deteriorates from A to B1, B2, extensive B line to C, this is very bad. But when you see the patient going from C to B and then to A, your patient is improving. And you might consider to extubate those type of patients. Lung ultrasound, lung score, when it was tested, the higher the score, the more finding you see. To simplify it, the more abnormal finding you see in your patient's lung at the time of weaning, spontaneous breathing trial, or at the time of extubation, the more that you have to be handicapped before you take your patient's tube out. Otherwise, you're gonna go to a failure. How to optimize this? Whatever you are dealing with, you have to treat. Extravascular lung water needs diuresis, needs even to consider CRRT and fluid removal. A wet lung wouldn't tolerate weaning. I'm repeating this. A wet lung wouldn't tolerate weaning. And the evidence showed that even in acute management of ERDS, dry lung was found to be better in outcome than wet lung. Of course, you have to weigh the risk and benefit of over-diuresing. You should not over-diurese, but you diurese the lung to minimize as much as you can the B lines or the extravascular lung water. Otherwise, also consider to drain the effusion, to make the consolidated collapsed lung to recruit, and you even may put in mind to consider non-invasive ventilation after extubation. You extubate to non-invasive ventilation or high flow. The second very important organ that is usually forgotten, and people in critical care ultrasonography, they call the right ventricle the forgotten ventricle. And I love to call the diaphragm the forgotten muscle. The diaphragm should not be, ladies and gentlemen, forgotten at all, because the diaphragm carries almost 80% of the inspiratory function or the inspiratory effort in everyone, in every human being. And the diaphragm should be working in most of the time, day and night. It doesn't stop to work. And unfortunately, around 50% of critically ill patients, because of mechanical ventilation, regardless of the period of time that the mechanical ventilation was for, even if it's for few hours, the mechanical ventilation might cause detrimental injury to the diaphragm, and we call it ventilator-induced diaphragmatic dysfunction. At around quarter of the surface area of diaphragm will be lost because of mechanical ventilation, regardless of the time, because we hear this repeatedly. People, they believe that patients who are intubated for sake of an operation that lasts for a few hours are very safe to be weaned. And sometimes if you go back and review your history, your own history, that patients post surgery of a long surgery, they require to be reintubated immediately. And sometimes we wonder why. And we might say that this is patients are not fully recovered. You probably, if you surveyed some of our anesthesiologists, they would say, no, they were fully recovered. One of this reason is the ventilator-induced diaphragmatic dysfunction, and the diaphragm remain unable to generate the tidal volume because, again, 80% of the power of inspiration comes from diaphragm. You have to keep this in mind, that the deleterious effect of mechanical ventilation might last for a long time, might last for several days. And this is one of the common reasons for mechanical ventilation dependency or failure to wean. There is no doubt, because as much as you rely on ventilator and you forget your patients on controlled moods, and you don't allow spontaneous moods, and you don't stop the muscle relaxant or avoid to use them if they are not necessarily, and if you do not consider the synchrony that your patient is tolerating and coping with the machine well, all of these factors will induce damage to the diaphragm, to the main muscle of inspiration. And you have to keep in mind again that around 10% of the thickness of the diaphragm will be lost in the first week of the ventilator. This thickness loss is what we call it atrophy of the diaphragm. And tell me, how can you see the diaphragm without lung ultrasound, without diaphragmatic ultrasound? You have to monitor the diaphragm. You have to see the diaphragm, not to hear about the diaphragm. With my all respect to other tools or modalities, you just hear about the diaphragm, but you don't see the diaphragm. Transdiaphragmatic pressure, the NAVA EDI, you just hear about the diaphragm. The pressure is this and that, but the ultrasound will tell you that this diaphragm is alive, is thickening with inspiration, is moving very well. No, it's not. It's thinned out or atrophied. It's contracting badly, asynchronously with the mechanical ventilation circle and cycles. All of these can be caught very nicely by the ultrasound, because the beauty of ultrasound that it gives you an eye on what you want to look at or to look to see. What we call it the eyeballing of the organs. I see the anatomy, and I see the physiology with critical care ultrasound. What I want to say here is that those who are not a fan of ultrasound has to change their mind, because you're going to gain a lot of advantages. When you assess the heart, you see the heart, you see it. And otherwise, you hear about the heart, blood pressure, mean pulmonary artery pressure, the pulmonary capillary wedge pressure by Swan-Ganz, the systemic vascular resistance by the pulsion or by thermodilution technology. Everything gives you numbers, but the ultrasound gives you vision. So you see this heart fit these numbers, this lung fits these numbers, this diaphragm fits the scenario. So I can. That's why all, and I'm saying all, I mean all, the societal guidelines recommend the diaphragmatic ultrasound to be one of the best tools, not inferior, but even better than sophisticated modalities. Like you can see the diaphragm with MRI, but how many of even radiologists who knows how to assess the diaphragm by MRI? How many among radiologists who knows how to assess and gives you number and function the diaphragm with the CT? How many of us has the capability of esophageal catheters of NAVA and EDI technology and the transdiaphragmatic pressure monitoring? This is very sophisticated. We see them in academic interested centers who do investigations, but in the bedside, practically seldomly we see them. So ultrasound, because it's available everywhere, everywhere. In a survey which we published very recently, we surveyed physicians working in Saudi Arabia, and I'm sure Egypt is the same, that we found in around more than 95% of the units, they have their own ultrasound machines. And actually, because I'm interested in this, I ask everyone whom I know working in ICU, different levels, and they say we have 1 or 2 machines everywhere. So what you need is to know how to use this machine bedside, and this is, again, is not something difficult to do. With the vascular probe that you use it to insert the central line, you can see the diaphragm, and you can see the thickening of the diaphragm, and you can test for the what we call it thickness or thickening fractions. With the echo probe, you can do the diaphragmatic excursion. How is this diaphragm moves? And I'm going to give you idea in this coming few slides very quickly in how we see the diaphragm easily, guys, easily. We put the vascular probe or the high frequency probe between the anterior axillary line and the mid axillary line, just below the nipple line or just above the costal margin, and you're going to start to see the liver. This is the liver, and we all know how to see the liver. This is the liver, and this is the venous system of the liver. As easy as that. This is the pleura of the lung. So this is the lower border, the middle and or the lower loop of the lung, and the lung is coming, encroaching over the liver here, expanding very well. This is what we call the opposition zone, the most freely mobile part of the diaphragm lies here. So when you put the probe and you see the lung coming and the liver is on the screen, as you see here, you look at the upper border of the liver, you're going to see line, hyperechoic line. This is the visceral part of the diaphragm. And another line in the middle, this is the crural part of the diaphragm, and another fine layer out of here, this is the third layer. And the diaphragm is composed with these 3 layers. So number 1, I see the diaphragm. Number two, I have to comment, is this diaphragm is thickening, increasing in size with every inspiration? How I know the inspiration? The lung comes during the inspiration. So look at the diaphragm when the lung comes like this. When the liver moves down, this is the inspiratory time. So, and then use your eye to see if this diaphragm thicken or not. And if this thickening is significant or not. Like any muscle, diaphragm is a skeletal muscle. When it contracts, the size of the muscle will increase. To have a winnable diaphragm, you have to have evidence that this diaphragm in a minimal pressure support or TP trial is thickening by more than 25% in most of the literature. So as simple as that. See the diaphragm, see if it's thickening or not, and this has to be done in minimal pressure support, the pressure support that overcome the resistance of the tube, 5 to 8 centimeter water. Or if you can, put your patient on TB trial, and then you do this study will be much better. Or put your patient on zero pressure or tube compensation if you have this mode in your patient's ventilator. You might zoom on to see details of diaphragm. Zoom on, you decrease the depth to see more details. So this is the first layer, cororal part, the parietal layer of diaphragm, and I see clearly that this diaphragm is thickening very well. So I have evidence now that this patient diaphragm is contracting well. Look here, this is the liver, this is the layers of diaphragm, and here there is fluid above the diaphragm. This is pleural effusion. And look at the diaphragm thickened very well with every inspiration. I'm happy to wean this patient off ventilator, despite I have to be sure that this pleural effusion is not significant, as I'm going to show you later on. Eyeballing, use your eye to assess the thickening change, during the expiration and during the inspiration. See how much change happens to diaphragm thickness with inspiration, and this might be enough. You should not go with the sophisticated measurement of the thickness by using this calculation. Thickness fraction is the thickness during inspiration minus the thickness during the expiration divided by the thickness at relaxation, which is expiration, times 100. We can do this by M mode, and you can rely on the eyeballing. The normal thickness for majority of human beings is around 3 millimeter, which is 0.3 centimeter. In critically ill, most of the patients are at the lower border of this normal because of mechanical ventilation and critical illness-induced polyneuromyopathy, because it causes atrophy of the diaphragm. As we mentioned, 25 to 30% thickening change will predict success with a sensitivity of more than 88%, and this is very good percentage. Another very important point, which is when you have a very complicated effusion, as you see here, with a lot of adhesions here and fibrin debris into the angle of the lung, encoring, this is the diaphragm, attaching and dragging and not allowing the diaphragm to expand. You have to deal with this effusion and this adhesions before you attempt to wean. Otherwise, the diaphragm will not be freely working or has the freedom to work. The excursion is something that found by literature to be also beneficial. We use here the echo probe. We put it under the costal margin in the abdomen, as if you are trying to see the gallbladder, but you look to see the liver, and then you see the diaphragm scooping the liver like this, and then you fire the end mode, on the diaphragm, and you see how much it goes above the baseline. This is what we call it the excursion. This is important, but you have to have a spontaneously breathing patient, not at all attached to any sort of mechanical ventilation, because the positive pressure per se might push the diaphragm down. So it gives you excursion that is not because the diaphragm working, but because of the effect of positive pressure. I'm not here to make you feel that this is a difficult task. I'm not going to learn this. I need a lot of training and a lot of no, believe me. We all started like anyone who started, that we see how the people do it. And we go and practice, read, see videos, do some very simple few courses. There are a lot of courses in Egypt and everywhere. Do this training bedside, hand-on, and then you're going to practice it. And believe me, this will make difference in the outcome of your patient. If you believe in this, you're going to start the journey. And this excursion can give you a lot of other advantages, like that you can see and diagnose exactly if your patient is synchronous with mechanical ventilation or not. If your patient is connected to ventilator, you diagnose the diaphragmatic paralysis. If you see the waves goes to the opposite direction, this is paralyzed diaphragm. If the diaphragm is flatline, this is paralyzed diaphragm. As I mentioned, you can see the patient ventilation synchrony. If your patient is still connected to a ventilator and you do these waves, you display the mechanical ventilation into the screen of the ultrasound, and you display the diaphragm to the mechanical ventilation cycle. If they coincide together, this patient is synchronous. If they don't coincide together, this is asynchronous. When the diaphragm and lung exam was co-joined together, the outcome prediction was much better. So you predict the success or failure when you have both lung and diaphragm examination together. One of the common mistakes that we have in ICU is that we rely on the pressure support blindly. And you have to keep in mind that though the pressure support ventilation is one of the best modes for synchrony, but still can have a lot of asynchrony. Not only that, but also pressure support ventilation, the blind pressure support ventilation might over-assist the diaphragm. Your patient's diaphragm might not like the level of pressure support you are choosing because you choose it blindly. And again, one of the good modes, as Dr. Abu Shadi mentioned, that gives you a lot of advantages when you have the NAVA. I'm not sure if you have NAVA in Egypt, but NAVA, which I'm a fan of NAVA actually. We work with NAVA in most of our winnable patients. We win them to NAVA. It gives you a lot of advantages that like wasted effort when the diaphragm contracts but the cycle doesn't open, or when the diaphragm is not coinciding with the cycle of ventilator. Look here, the diaphragm finished while the inspiratory time is still there. The diaphragm contract during the expiratory time, and so on. But the most important thing that the over-assessed, this patient was in pressure support of 17 over PEEP of 12. Diaphragm sleeps, doesn't work at all. So you have to keep in mind that to keep the function of diaphragm, to monitor the diaphragm, to have evidence that the diaphragm recovered or recovering before you attempt to extubate, otherwise your patient will fail. The last but not least, the heart. As we know, the positive pressure ventilation carries a lot of change to the right side and left side of the heart. For the right side, the preload will reduce, and for the left side, the preload will increase, and the afterload of the right side will increase, while the afterload of the left side will decrease. So if you have somebody with cardiogenic pulmonary edema, they improve once you put them into positive pressure. Why? Because the trans-aortic pressure will reduce, And so the afterload will reduce, and the ejection of the heart will reduce. The environment for the left ventricle to eject the blood will be better. And at the same time, the preload of the right ventricle is reduced. The amount of the blood goes to the pulmonary circulation will reduce, and so on. But when you attempt to remove this assisted positive pressure, the intrathoracic pressure will decrease. And this might carry a lot of changes into the venous return. It will increase. The filling pressure of the left ventricle will increase. The afterload of the left ventricle will increase. And this might induce both systolic and diastolic left ventricle dysfunction. Cardiac dysfunction is found to be the reason for weaning failure in around 42% of the patients. And this happens in every mode of weaning, regardless the TPs or pressure support. But of course, the TPs was found to be the most frequent compared to CPAP pressure support. So the evidence of cardiac injury with the TPs is unfortunately higher statistically compared to CPAP pressure support, to the same reason I mentioned, because of the sudden release of the afterload of the afterload will increase for the left ventricle, and might cause cardiogenic pulmonary edema. So what way you assess your patient's cardiac function before you wean? Do you wean your patient without looking at the heart, without knowing if your patient's heart will tolerate this stress time? This is detrimental again. Because to start with, the heart might be still weak to tolerate this weaning. Or this patient's heart started to weaken once you started the process of spontaneous breathing, or immediately after you stop the breathing, spontaneous breathing trial, and you attempt to extubate, immediately group of patients reaching up to 40%, they goes into pulmonary edema. So how we assess this, how we predict this before it happens? Echo plays a major role. There are a lot of other things, invasive and non-invasive, laboratory and non-laboratory, but all of them, they lack the good sensitivity and specificity of seeing the heart. Look at this patient left ventricle here, and you are trying to wean such kind of patient. The left ventricle is not contracting well. The left atrium is full of blood, as simple as that. So this diastolic function is impaired and systolic function is impaired. And if you have systolic dysfunction, you have to keep in mind that there is eventually the diastole will be also dysfunction. How can you wean somebody with this bad systolic function? You have to work on this systolic function to improve this contractility, to reduce the amount of volume inside this heart chambers before you wean. Otherwise, immediately after you take off the positive pressure of this patient, the afterload will go higher, the heart will fail more, the filling pressures will increase more, and the pulmonary edema will ensue immediately. So you have to have evidence that ejection fraction is maintained, cardiac output is maintained, the filling pressure is not high, the left atrium relaxes well, left ventricle relaxes well and contracting well. And again, the eyeballing of the left ventricle and right ventricle is enough. Tell me, if I ask you, even if you are not expert, and I just need to tell you that this is the left ventricle, which is at the left on the screen, and the right of the screen is the right ventricle, and both ventricles are sitting at the top of the screen, one or two views, and you're gonna be identifying very well the anatomy. and you know how is the normally contracting left ventricle will behave like, then you're not going to miss that this left ventricle here, left ventricle here, left ventricle here are not contracting well at all. And the blood is stagnant into the ventricle. And this patient's left ventricle need a lot of effort before you attempt to wean. They need inotropes. They need afterload reducing agents. They need diuresis. They need them to be monitored for a while to ensure that they did well after adding all of this. You need to add a preload reducing agent like nitrates, dobutamine, levosimendan, whatever is afterload reducing, hydralazine, nitrates with a calcium channel, ACE inhibitor, whatever you go with, just by eyeballing. Eyeballing will tell you that this lung is flooded with fluid and this lung is aerated well. Again, combining the examination of heart, lung, and diaphragm was found to be associated with better outcome and best outcome for weaning process. And this is just to sum up, before you start your spontaneous breathing trial, be sure that the heart is fine, lung is fine, diaphragm is ready. Once they are ready, start the journey of breathing, spontaneous breathing trial. During the spontaneous breathing trial, be sure that the heart is tolerating, lung is not de-recruited, diaphragm is working, and then off the pressure, the ventilator, and put your patient into two TBs. And then before you take off the tube, be sure that these three organs are still doing well. And by here, I would conclude, and thank you very much. And sorry if I take a lot of time. Thank you very much.
Thank you, Dr. Ashraf. Really, we enjoyed this session. It was very useful, and actually, we enjoyed it too much. There are some questions from the floor, please. First, can ultrasound be diagnostic or only suggestive of diaphragmatic paralysis? Is it a clue, or it's a sure sign of diaphragm paralysis if we want to diagnose diaphragm paralysis?
Very good question. As I showed you, when you are able to see the diaphragm, then any diaphragm, of course, you minimize the pressure support. If you are able to put your patient into TBs before you assess, will be better. But the diaphragm can be seen even in intubated, ventilated patients. Of course, they have to be off sedation. They have to be with no muscle relaxant, ready to wean. And then if you see the diaphragm is not thickening and it doesn't move at all, this is paralysis. If your patient is on a TPs or extubated, the excursion by the echo probe, when you put the probe into the abdomen, just below the costal margin, looking at the diaphragm, and you see that the diaphragm, the liver moves, but diaphragm is not displayed down to come toward the probe, and you don't see the curve up, you see flat line. This is paralysis.
Yes.
This is paralysis. If you see paradoxical movement of this excursion, the diaphragm moves away from the probe, this is diaphragmatic paralysis.
Yes.
So it's better than the fluoroscopy.
Oh, yes.
It's more sensitive and more specific. The only thing that you have to know how to do it. And again, easy to learn.
So another question about the prevalence of asymmetry between both diaphragm, right and the left. How prevalent is it, and does it have any impact on the pulmonary function or the weaning? Or
very good question. Very good question. Thank you very much. Here, from the ultrasonographic point of view, most of the experts and the literature are recommending to go with the right side assessment and not to go with the left side, because the left side is difficult. And this is, I'm trying nowadays with our current research to prove that this is not ideal for the patient care. You have to see both sides, because you might have one side affected and the other is not affected. One side can generate good tidal volume and can compensate for the other side. If the one side is weak and the other side is less weaker, they will compensate. If one side is paralyzed because of injury, because of surgery, because of post-cardiac surgery, because of whatever it is, the right side is impaired or injured, but the left side is still intact, yes, patient can be weaned and can tolerate. Why? Because the two diaphragms help each other, and the intercostal and accessory muscles do around 20% of the job also, and this will add to the functioning diaphragm. Bottom line, assess both sides, learn how to do the right and left, and don't stop on one side. In my presentation, one of the international conference that we do every year, I presented cases of where the left side was enough when we saw it functioning to rely on to wean patients. And the message is, don't stop and don't be deceived by examining the right side only. This is very important, and thank you for the question.
Thank you very much, Dr. Ashraf. Really, it was a very great topic and session you gave us today. Hope you will join us frequently whenever your time allows, please, Dr. Ashraf. يعني أنا فعلا استمتعنا واستفدنا جدا بالمحاضرة دي، ويعني نشوف حضرتك على خير قريب بإذن الله، وربنا يخليك جدا، ويعني شكرا لوقت حضرتك والامتعنا بالمحاضرة الجميلة دي.
أنا اللي بشكركم على أنتوا اديتوني الفرصة العظيمة دي إن أنا أكون معاكم.
ربنا يخليك دكتور أشرف، وشكرا دكتور عبد الرحمن، وشكرا لكل الحضور اللي حضر معانا، واتعشم ان احنا نشوفكم قريبا ان شاء الله في يعني ايفنتس تكون مفيده يا رب باذن الله للناس، ويعني نشر العلم يكون حاجه يعني في ميزان حسنات الناس كلها. شكرا جزيلا ليكم جميعا، وثانك يو فيري ماتش.
شكرا.
شكرا جزيلا دكتور اشرف. شكرا على خير ان شاء الله.
اشوفكم على خير ان شاء الله.